start touching on
Sure.
some of the questions?
Great. Thank you. And Mary, I'm going to ask you to move your microphone just a little closer to your mouth so
Oh,
that
sure.
way.
Thank you for
There
letting me
you
know.
go. Excellent.
Great.
Thank you. And just for those of you that are attending today, we are happy to take your questions throughout the presentation. So please do put them into the chat box and Jenny will be sharing those. We can try to address them as we go through as well as at the end of the presentation. So thanks for the initial kickoff for this. Tell me what we know about the impact of dietary intake on hypertension.
Yep. So if we could go to the next slide, perfect. So like I mentioned, there's a lot of factors that contribute to hypertension. And one of the major modifiable risk factors for hypertension is dietary intake. So what we eat, both good and bad, can impact our cardiovascular health in the short and long term. So kind of negative components like high sodium diets, those diets high in saturated fat or alcohol are major components that have been shown to increase blood pressure through various mechanisms of action. And then kind of on the contrary, fruits, vegetables, nuts, just a few, for example, have been shown to improve blood pressure as they're rich sources of various micronutrients, bioactive food compounds, and fiber. So on the basis of evidence from clinical trials, meta-analyses, and systematic reviews, current clinical guidelines recommend lifestyle changes as the initial treatment for those who have the prehypertension or elevated blood pressure category, and then also as a complementary aspect of pharmacological therapy in those that have hypertension stage 1 or 2. There is some ambiguity, though, among practitioners about what benefit is likely achievable from these non-pharmacological approaches and which dietary approach to recommend. So I just wanted to start by kind of highlighting the research that is being done in recent years and currently on dietary intake and hypertension. So there's a focus on looking at whole lifestyle habits, so diet, smoking, physical activity, etc. Then specifically dietary patterns, so overall what you're eating. And then also single foods and or food components like certain dietary bioactive compounds or antioxidants. So we can go to the next slide, please. So focusing in on that single food source or a bioactive compound, one that's gained a lot of traction in recent years is inorganic nitrate. So nitrate was kind of previously mischaracterized by the media as being harmful for human health. But when you're consuming nitrate in its most abundant form, which is actually found in green leafy vegetables like arugula, it's actually beneficial. It's where it becomes problematic is when it's in your meats and cooked to certain temperatures. But basically, nitrates have been shown to be converted, nitrates from foods converted to nitrite, and then eventually to vasodilatory nitric oxide to promote blood pressure regulation. And so on the screen here, I just present results from a recent meta-analysis because again, nitrate interventions have gained a lot of traction. And in this meta-analysis, they found that nitrate interventions, whether that was a food-based nitrate, beetroot juice, or even nitrate salts, they found significant reductions in both systolic and diastolic blood pressure compared to control groups. And this was about 6 millimeters of mercury and about 2 millimeters of mercury for systolic and diastolic respectively. Okay, and if we can move to the next bullet point. Okay, and so that brings me then to more of a dietary pattern focus, which is the DASH diet. So the DASH diet encourages fruits, vegetables, and whole grain with a focus on fat-free or low-fat dairy products, fish, poultry, beans, nuts, and vegetable oils. And this diet recommends to limit foods that are high in saturated fats, sugar, sweetened beverages, and various sweets. And it's proposed that the benefits are derived, again, from its potent source of micronutrients, and also a lot of its benefits are attributed to being a rich source of inorganic nitrate. And I didn't include just one meta-analysis here because the DASH diet has had a lot of research over the last 20 plus years that have shown that those who adhere to a DASH diet have significantly improved blood pressure outcomes compared to control groups. And then these benefits can be amplified by DASH diet and physical activity. Okay.
Thank you, Katelyn, for that information as well. So when we think about this in the context of going from kind of population health down to individuals, what are some of the proven ways that people can change their diets to improve their hypertension risk?
Sure. And before I launch into that, do you mind if we just back up a little bit and talk a little bit more about some of the evidence that we found in this systematic review that we looked
Sure.
into? Is that okay, Jeannie?
Sure.
Okay. And then I was just thinking on this slide, Katelyn, it might be helpful to even just give a couple sentences about what a systematic review and meta-analysis are, just for people who aren't familiar.
Yes, of course. So basically, a systematic review and meta-analysis is really helpful when you're trying to bring together all these individual studies and look at overall, are we seeing similar patterns or overall benefit? Because when there's so much research in one area, you might see different effect sizes or different changes in each study, some positive, some negative, some null. So a systematic review and meta-analysis just helps to bring together all of the evidence on a certain topic and see, when we combine all the evidence, are we still seeing overall significant changes in the direction we would hope for? And so we've recently conducted just that, a systematic review and meta-analysis. So this is on the topic of medical nutrition therapy. So it kind of brings together everything I started talking about on the last couple of slides and that Mary had introduced about medical nutrition therapy. But briefly, I'll just re-highlight what MNT is. So we abbreviate medical nutrition therapy as MNT, and it's the application of our nutrition care process, which is a systematic approach that nutrition and dietetic practitioners use to provide nutrition care. And it encompasses nutrition assessment and reassessment, diagnosis and intervention, and monitoring and evaluation. And overall, it's used to promote healthful eating patterns and improved health. So bring us to this specific systematic review and meta-analysis. Kind of the reason behind it was that in 2015, the Academy of Nutrition and Dietetics Evidence Analysis Library published an evidence-based nutrition practice guideline that recommended MNT provided by a registered dietitian as an effective intervention to reduce blood pressure in adults with hypertension. 2015 doesn't seem too long ago, but as in recent years, research is moving along fast. And so we've seen a lot of involvement in the way registered dietitians practice, research practices. And so we wanted to conduct an updated systematic review and meta-analysis that looked at medical nutrition therapy and its influence on cardiometabolic outcomes in a prehypertensive and hypertensive population. So our specific research question is at the top right of the screen. So in adults with prehypertension or hypertension, what is the effect of MNT provided by a dietitian or the international equivalent compared to a standard care on blood pressure, hypertension incidence, medication use, anthropometrics, and CVD risk? So we included a whole host of outcomes, but I'm going to narrow in on just a few while I review this. So that was our research question. Now, what kind of articles did we include? We only looked for randomized controlled trials because these are the gold standard pieces of evidence. And so we include randomized controlled trials published between 1985 and 2022. And to be included, these RCTs must have had a population of adults that were in an outpatient setting. So they just couldn't be inpatient. They had to be at least 18 years of age. And then the intervention, most importantly, had to be led by a registered dietitian or an international equivalent. And that could be done either independently or as part of a multidisciplinary team. And the intervention itself had to encompass medical nutrition therapy or nutrition education. Our control group was usual care or no intervention. So typically usual care is just a one-time meeting with the physician where they provide standard materials that the physician would provide to any patient that had hypertension. And our outcomes of interest were hypertension status and blood pressure and change in anti-hypertension medications. And some of our secondary outcomes were cardiovascular disease events, risk, hospitalization, vascular function, etc. So we used gold standard methods to conduct this systematic review. So we assessed risk of bias using the Cochrane risk of bias tool version 2. And we also assessed the certainty of evidence using grade methods. And so this just allowed us to not only combine all of the evidence and see what the changes were, but then to assess whether the individual studies possessed risk of bias and how certain we are in the findings. So it kind of looks at the results comprehensively. So in total, we identified nearly 5,000 articles when we conducted our initial search, and that dwindled down to about a final number of 40 articles that represented 31 trials that met our inclusion and exclusion criteria. And the results I have highlighted on the screen here for our meta-analysis is that we found a significant reduction in resting systolic and diastolic blood pressure by about 3.5 millimeters of mercury for systolic and 2 millimeters of mercury for diastolic. And let's see, I'll dive into our subgroup results for blood pressure here too. So like I said, our main focus was an MNT intervention conducted by a registered dietitian, but we wanted to see if different components of the intervention or the study might have influenced these results. So we looked at subgroup analyses and found that both interventions led by a registered dietitian only or by a registered dietitian as part of a multidisciplinary team had significant reductions, but a greater reduction was found when the dietitian with a dietitian only led intervention, which we thought was an interesting approach that advocates for medical nutrition therapy. We also found that there was no differential effect by way of medical nutrition treatment as part of a group or individually conducted, or if it was in person or remote. So that kind of demonstrates that MNT is helpful regardless of the setting it's conducted in, which provides further opportunity for implementation. And then we also looked at studies that included those who were pharmacologically treated for hypertension and those who were not being currently treated for hypertension. And both found reductions in blood pressure, but a greater blood pressure reduction was found in those who are not currently treated. And then moving on to some other outcomes I wanted to highlight, we also found significant improvement in the use of anti-hypertension medication in our MNT treated individuals. There was an improvement in the relative risk of stroke and overall 10-year cardiovascular disease risk score. So I know that's a lot of information all at once, but overall we did find that medical nutrition therapy provided by a dietitian improved blood pressure related outcomes in adults with prehypertension or hypertension. So we're excited to see moving forward how we can implement these results.
Great, thank you so much, Katelyn. And the reason I wanted Katelyn to kind of dive into the science first thing is just to demonstrate before we start that this type of nutrition intervention really can work. I think sometimes when people get hypertension, it can be, a thought of, okay, am I just trying this before I slide into medication and more comorbidities and interventions, but even looking at randomized controlled trials, we can actually prove that this type of nutrition intervention can work. And I think the key to that, it really is sometimes hard to see in research the effect of these lifestyle interventions. But I think the key is that we really did restrict interventions being delivered by dietitians. So people who really were trained to provide counseling and evidence-based care. So going back to your question, Jeannie, sorry, I went around a long way before getting back to it, but how can adults change their dietary patterns to improve outcomes? So Katelyn highlighted some specific dietary interventions that have proven effective, and I'm going to talk about some more that we found in our research. But overall, I just wanted to emphasize the fact that really there is no one size fits all solution. And that's kind of one of the cornerstones of medical nutrition therapy, that we're working with each client individually to see what will work for them and taking their current circumstances and goals and health status and working within that context. I'm sure we've all heard a lot about personalized medicine, and in that same token, we think about personalized nutrition. What is this person's genetics and what has their past exposures been? So there's a lot of things to consider when you try to think about what's really going to help this person. And providing MNT through dietitians can be one way that we can work with all different kinds of people from all different kinds of backgrounds to help them understand what is going to work best for them. The last thing we want to do is, prescribe a dietary intervention and the person goes home and forgets they ever we're going to try it all. We want to do something that's realistic and that's going to work for them and will help them see the results that they want to see. So Katelyn touched briefly on what this process entails. So the first part of it is screening, where the health professional is working with the client and just kind of doing these overall screenings to see, okay, where are some major issues going to be? For example, we're going to see what is their nutrition status. Are they underweight? Do they have overweight or obesity? And just kind of some of these big picture questions. Then we're going to move on to a more detailed assessment that includes the client history, their anthropometrics, their biochemical, other factors such as blood pressure, and what that person's specific circumstances and goals are. Once we've worked with that client, then we might create a nutrition diagnosis, and hypertension is certainly nutrition related diagnosis. So we would work with this person and their physician to create an intervention that's going to work for them. Usually it's a lot more simple than people think. We really start simple and have these realistic, reachable goals. And then the idea is to have continuity over time where you can build on that. And the thing about people is that they're always changing. Not only are clients different from each other, they're different from themselves, from consult to consult. So there's changing needs, there's changing dynamics, there's changing goals. So this is really kind of a continuous cycle. So one more slide about individualizing care is that really every person has so many different things they can work on, especially for most of us working in the United States. Individuals rarely come in when they're healthy, and when they have one comorbidity, such as hypertension, it usually comes with a lot of other things. So it's really about helping them kind of break apart, where can we start, where can we make this first step? And before we move on to the next topic, I just wanted to kind of add on to some of the components that have been shown to be successful. Katelyn talked about some of these in the greater literature, but we also found a lot of these same components aligning in the systematic review that we did. So basically what we did was, as Katelyn said, we did subgroup analyses. So we looked at, for example, what was the effect of the studies in which the dietitian prescribed a DASH diet versus when they didn't. And we would look and compare how effective those different types of interventions were. And no surprise, but also very nice to see, interventions with the DASH diet did show a greater improvement in outcomes. We found that interventions with caloric restriction had a slightly greater improvement, but just a caveat side note, all of these, were done before obesity medications came onto the scene in kind of a major force. So this wouldn't necessarily always be appropriate for every client now. Interventions with sodium restriction did show a slightly greater improvement in blood pressure, and interventions with physical activity showed a greater reduction in body weight. Okay, so sorry again, that was a very roundabout way, Jeannie.
No, that was
answering
great.
your question about how to address
It's always
hypertension.
always great to hear about the evidence. I think all of this sounds great, and we know that there could be improvements in the hypertension levels just by these types of interventions. But what are some of the barriers or challenges to adults receiving these evidence-based nutrition interventions in real life?
Yes, absolutely. So everyone, I think it would be great if every person got to go visit a dietitian or got to go visit a trainer or, a mental health specialist or any specialist that they need. But of course, most of us no matter how much we think about it, we never quite get to that for a myriad of reasons. So for most of us, a big reason is cost. If you're going to do a couple of times a month and pay a healthcare professional, it's going to cost. And for nutrition interventions, it's not always going to be covered by public and private payers. Some disease conditions are covered for medical nutrition therapy, for example, type 2 diabetes. But conditions such as hypertension are going to be a lot less likely to be covered under all payers. So that's a huge barrier, because people will often have to pay out of pocket, or maybe they can do research to see how they can get it through their employer or through a community program. But of course that's effort, and all of us have limited time and energy, as well as money. So of course this really has to be a high priority of someone saying, I want to pursue these lifestyle interventions to address hypertension, because we all have limited time. Transportation can be a limitation. Luckily, this seems like less of a barrier kind of in our new technological world, especially post-COVID. More of us have tools for telehealth, but these in-person initial counseling sessions, we always encourage. So even getting to these in-person appointments in the first place can be a challenge for people. Lack of childcare, and also just different life priorities, like nutrition and health are really important, but there's a lot of other competing priorities as well. So all of these can be barriers. And I'm happy to also hear from Katelyn or from you, Jeanne, about other thoughts on barriers.
Katelyn, do you have anything you want to throw in there before we talk about solutions?
No, I think Mary hit all of the ones that I would also acknowledge as both in research and clinical practice are major barriers to seeking care.
I also wonder if just the link between hypertension and thinking of it in terms of cardiovascular disease or to other long-term chronic diseases, the role that it plays, for example, in kidney function and long-term implications with levels of blood pressure and then the ability of the kidneys to function, that people might not make that association when they think about elevated blood pressure, not calling it hypertension, not understanding how it fits in with the other chronic diseases. So therefore, it doesn't really seem as much of a priority to get the nutrition care to make the changes that might be necessary. So we understand these barriers, and obviously there are some solutions that can address each of these bulleted items. So Mary and Katelyn, why don't you walk us through what you see as some of the solutions?
So I can go ahead and just provide some more research and clinical experience examples. But I like how you mentioned previously, just like how you look at hypertension might impact your ability to seek care. So I do think that's common, is looking at high blood pressure is maybe just another thing that everyone gets, but it's not actually cardiovascular disease, so you don't need to worry about it yet. So I think if we can just overall do a better job with messaging about hypertension is a very important risk factor that you can manage early life, and even prevent, to then prevent the comorbidities and disease onset down the road, that might help with motivation to seek evidence-based care if it's possible for them. And then I work in clinical research, and so one of the major barriers that's addressed in seeking evidence-based nutrition care applies to also participating in advancing this research area is transportation. And something I've seen both in research and clinical practice is that more organizations and hospitals are starting to offer transportation vouchers if someone doesn't have their own vehicle to get to the appointment. They can use services offered by the healthcare system or private systems like Uber or Lyft and be reimbursed, or receive a voucher in advance, which has helped with both participation and attendance at visits. And then just providing multiple means to actually get this care. So traditionally, a lot of evidence-based nutrition care or just research and healthcare in general is in-person visits. But kind of in the era post-COVID, we are seeing a lot more options with virtual settings like telehealth, and just being able to get this care and recommendations while being at home. If you have access to a phone with a camera or a computer, if you're able to kind of eliminate the commute as a barrier and just pursue this care in your own home, that's also very helpful. So I'll go ahead and pass it off to Mary.
Thank you so much, Katelyn. So I'll talk about it more from like a practitioner dietitian perspective. So one of the main initiatives that we've had is really to promote these principles of inclusion and diversity and equity and access. So we really try to think about at every stage of care, how can we improve access to care from many different perspectives. So I think access to care often references the cost of the care, but as we've seen, there's a lot of other barriers. I think one thing that we also did put up there is cultural or language barriers. So there's a lot of different factors to consider in trying to improve access to care for our clients. So one of them is just to try to be as flexible as possible about how care is provided. So in-person or blended care are both effective in improving blood pressure, although when we looked at the studies that did remote care only, they didn't have a significant improvement. So it's kind of showing how telehealth can really be a great tool, but it to be efficacious, maybe it would be optimal to do it in the context of both in-person and remote kind of blended care. Another way to increase access to care and decrease cost is to do not only individual care, but also group interventions or a blend of these interventions. So again, in our research, we found that both individual and blended individual and group were efficacious, but group only wasn't. So just kind of thinking we do want to be working one-on-one with these clients at some point, but it doesn't need to be at every single consultation. And providing remote care and group interventions offer their own benefits, if they're balanced with in-person and individual, because in telehealth, for example, you can be with a client in their home, you can walk through their kitchen with them, really see kind of what their food environment is and really learn a lot about the client. So telehealth can play a really important role in counseling. And same thing with group, it can offer some really unique benefits, which is people talking together about what works, getting support from each other, and just understanding that this is a common problem to be addressed. So we also found we looked at the how efficacious different interventions with different durations were, and we found that really even shorter interventions that were under 3 months, over a month, but under 3 months, they were still efficacious. So really any type of nutrition counseling that we can get is better than none. And I apologize, I forgot to put the reference on this. This is from a position paper that just got published in the Journal of the Academy of Nutrition and Dietetics, and it's about providing interventions in the general population. So it's very relevant to this topic because so much of the population does have hypertension. But here we just give some ideas or some overview of different ways to think about improving access to care. So for example, having resources that we can give to clients that are tailored to them when possible, being as flexible as we can about scheduling both in the ways I talked about in the previous slide, but also time of day. Can we improve access by making a 5 p.m. appointment or making a 7 a.m. appointment? Other ways are that you could think about offering packages to clients where they're going to get multiple contacts for less expensive per contact than if they did single contacts, or you can work with interdisciplinary practitioners to provide package interventions, and really just not being afraid to talk with clients about how they can support their interventions, either through their employer or through their insurance or other resources. So these are just kind of some different ideas for thinking about access. There's no, again, one size fits all solution, but kind of just thinking about it in different ways. Jeannie, do you have thoughts? Oh, you're on mute.
Or if you want to go ahead and go to the next slide, I'll talk a little bit about overcoming some of the coverage and payment challenges. And you had mentioned just the need for these services across the, both adults and seniors. And so when it comes to Medicare, we know that right now we're limited to diabetes and renal disease. We do have a bill that is currently in the Congress, and it's listed here, the Medical Nutrition Therapy Act. It would allow for additional chronic diseases to be covered by Medicare fee-for-service. The importance there is that it would then transcend into some of the Medicare or into the Medicare Advantage plans. We are still going to have that challenge with other payers. And I think that that's an area that I want to touch on when I get to the end of this slide about how the roundtable and the participants can help with this particular area. But in addition to increasing the number of chronic diseases and conditions, it would also allow for non-physician providers to refer for services. So thinking of rural areas and some of the challenges we're having with access to care and the shortage of primary care physicians, nurse practitioners, physician's assistants, psychologists would be able to refer patients for medical nutrition therapy. And there's many ways for those who are attending today to get involved. At an organizational level, we have a sign-on to support the bill. We also have a letter that is circulating during the month of August that will go to the committee chairs for both the House and the Senate committees of jurisdiction that we would welcome sign-ons for. We also host a monthly MNT advocacy group, and this group is comprised of lobbyists from different organizations that are interested in increasing coverage for MNT. So welcome any of you that are interested in participating. If your government affairs folks want to join us, we would be happy to have you. And then finally, there's action alerts on this bill to send stories and examples to members of Congress to try to tell your story and encourage them to sign on in support of the bill. And so before I turn it back to Mary and we start to think about some of the questions that you might have, I think in terms of the roundtable experience with this medical nutrition therapy piece, that there are conversations we've had with regard to regional payer coalitions and some of those other areas. And so certainly this bill addresses it with Medicare, but there's lots more conversation to be had about coverage and payment and places within the roundtable that we can look at. What do we need to do to increase access to nutrition care so that it's equitable, so that it's part of, not only prevention in terms of hypertension, but it's actually part of treatment as well for those individuals that are living with a chronic disease. And with that, I think we are at the question phase of the presentation. So Jenny, I'm not sure if you have had any come through the chat box, but I'm happy to start with one for Mary and Katelyn.
I don't see any questions yet. So feel free to ask Mary and Katelyn, then I actually have a question when you're done.
Sure. So going back to MNT versus access to nutrition care, and you have this overarching DASH diet that is something that a lot of providers are able to share with their clients. How do you get to MNT? So would it be that, how would you identify the people? And in your research, so this is kind of a part B to the question, people seem to equate those two things, that access to nutrition information is the same as MNT. So would you expect the same results that you posted in your research if it were different providers or if it was not provided by a registered dietitian nutritionist?
Katelyn, do you want me to start or do you want to start?
Yeah, you can go ahead and start.
Okay, great. Thank you. So I think you bring up a really important point, Jeannie, that about nutrition education versus nutrition counseling. So nutrition education is certainly extremely important. We have national initiatives to encourage all healthcare providers to talk about nutrition, to understand what the population recommendations are, and to help, their clients understand those too, as well. However, kind of an added step is this nutrition counseling, where you're actually working with the client to help them individualize those recommendations into their own lives. So medical nutrition therapy is specifically about providing nutrition counseling and individualized interventions for people who are at risk of disease or who have specific disease conditions. So other healthcare providers may not have the training to understand what specific recommendations should be used for these specific conditions and how to tailor those recommendations to the client that's in front of them. So we want everybody to be talking about nutrition and emphasizing the importance of nutrition, because we know it is such an important risk factor and treatment intervention for this condition of hypertension. But really working with a qualified nutrition professional, a registered dietitian, is really going to make sure that those recommendations are appropriate and that they're incorporated into a way that the client understands and can be successful with. And one of the reasons that we limited the systematic review to interventions delivered by dietitians was for that exact reason. We wanted to know, okay, when nutrition is delivered under these optimal conditions by qualified practitioners, does it work then? Because really, when you look at all the nutrition interventions all combined, it usually doesn't show an effect. But when we show interventions delivered by dietitians, we do see an effect. Katelyn?
Yes.
Got a
Ah,
couple.
oh
Do you
yeah, I
want to
don't have any.
respond to that one, or we've got a couple more questions in
Yeah.
the chat box? I know Jenny had one, and I see one on Q&A. So Jenny, why don't you go
Great.
first, and then we'll get to the
Yeah,
additional questions.
sure. This is more of a global question, given my position versus some of the questions in the chat box. So bear with me. But when you talked about all the barriers, I really appreciated that, because there are a lot of barriers. And what are your thoughts on how the roundtable can elevate awareness? Because in addition to payer challenges, I see a lack of awareness from even a PCP perspective. If you go in and you're diagnosed with hypertension, do physicians, primary care physicians, even know the value of working with a registered dietitian? And then if you're a patient in that exam room, where can you go to find a registered dietitian in your neighborhood? What are some of the links that you all may have in place as the academy, or that you know of, that could just help kind of ease some of those continued barriers to getting to medical nutrition therapy?
Jeannie, do you want to start with
Yeah,
that?
I can start. I think first and foremost, having an opportunity to present here today and to share this information with a think tank and with those that are interested in this area is a great first step, and would just invite us to continue the dialogue. We would love to be able to think about how presentations at annual meetings or coming to different coalitions or work groups to talk about this information, talk about what the evidence says and how it might be used. Consideration in value-based payment models, as we're looking at like what really makes a difference in chronic care, and how can the provision of MNT, bring value to a particular individual in their healthcare journey, and looking at it from both a payer and a beneficiary, both perspectives simultaneously. So I think the biggest issue now is having this dialogue. We know that there's not a lot of medical education related to nutrition, and what is there is more preventative in nature, or thinking of broad guidelines such as the dietary guidelines, not so much clinical application. And I'm certainly not saying that that's true across all different medical settings, because I think there are specific clinical areas where the value of nutrition is very much lifted up. But I think the problem is not just in terms of hypertension, that awareness also goes to the overarching picture with cardiovascular disease. We've got referrals in-house right now in hospitals. Those are opportunities to do some work with these individuals. There's opportunities to do so in community-based settings, but I think it's a continued conversation and advocacy work that we can all do together to increase awareness and then seek some of those coverage and payment options. Okay, anybody else have anything on that before we move to some of the specific questions? All right. So Alejandro asked, what would be the rationale for potassium leading to greater reduction in body weight? This was from the slide on evidence-based interventions for hypertension. And then Jamie tagged on with that along with Alejandro's question, comment on the effects of PELSS, potassium-enriched low sodium salt on blood pressure.
Yeah, that was really one of those relationships where you look across many things and a couple of things just don't make sense. I thought about not putting it on the slide because I'm really not sure about if there was a mechanism or if, there was a relationship between those, but felt that I wanted to be thorough and show where the results were. So, I don't think that there's necessarily a clear mechanism or relationship there, but maybe Katelyn, you have other thoughts.
Mm-hmm. Yeah, no, I agree with Mary on that. I think maybe why we're seeing that group highlighted is that these were all food-based interventions. And so when they're reducing sodium, they're reducing more of their processed foods or encouraged to reduce processed food intake. And then when they were encouraged to increase potassium, it was through food-based potassium sources. So your fruits and vegetables. So what comes with that, in addition to potassium, is more fiber. And so that could lead to potentially just feeling fuller longer, reduced body weight. So there might be kind of a plethora of mechanisms that contribute to it. So I think it's more of just the whole food diet in increasing your consumption of whole foods. As for the comment about the potassium-enriched low sodium salt, the next question kind of touches on that too. My research area is mainly in food first interventions. I'm a big fan of the food matrix because the food matrix is a way to, it's eating the whole food. When you're consuming the whole food, you're getting the vitamins, minerals, the micro or bioactive compounds in the food matrix. So that kind of helps to regulate absorption of certain compounds. So you're not getting too much or too little, or it can affect its absorption. And so that's my background. I'm not too familiar with these food products and the evidence that maybe supports their benefit or potential harm in reality. So if Mary, if you have any background on that.
I don't know enough about it to take a stand on it. However, I think that some of the different perspectives I know in the past, the obvious benefit is that we would potentially reduce the sodium supply from a population level. I know there are concerns about unintended consequences. So for example, one thing that comes to mind is that a lot of people have undiagnosed chronic kidney disease, and having really high potassium intake could be a problem because they can't regulate levels as well. But generally, having too high of potassium is generally not a problem for most people because, as Katelyn said, we're getting it in fruits and vegetables. But if it's added as a salt substitute, maybe you would get these really higher levels. That said, I think there's many people who would say the evidence, the modeling has been done, and that is not necessarily something that we need to be concerned about. So just kind of talking about different sides of the debate, and I think there still is a debate.
I would add to this conversation, we've been talking about the labeling and how to make sure that consumers have access to information. So relative to sodium and thinking about the impact on dietary intake, from the conversations we've had, it appears that if the table salt is around 11 to 15% of intake, so most of the sodium that individuals are getting in their diet is coming through other types of foods that they're consuming. It's not at the table, it's the foods themselves that are processed or have sodium added during the manufacturing. So I think that's a really important point to make, is that just working on table salt is one piece of a conversation, but if you really want to reduce sodium, then we're going to have to either work with consumers to choose different foods or to work within the food systems to make the foods that are available a bit healthier and to have less sodium. I do agree, Mary, we have commented that the addition of potassium chloride versus using sodium is, yes, an option, but when you have so many people living with chronic kidney disease and the number of individuals that are on dialysis, then you would need to also make sure that there was some type of information available on the label so that they could make informed choices when consuming foods. Okay, so Jim has a question on the flip side of the coin. What kind of food or drinks can increase blood pressure? Is it meaningful to examine those as well to educate hypertensive patients to prevent or replace?
Yeah, I can get us started with that one. So kind of on the flip side, foods that are high in sodium, so a lot of your processed foods in general are going to contribute to elevated blood pressure, high blood pressure. Foods that are high in saturated fat, and then also alcohol are major components that have been shown to increase blood pressure. And so with that, what would be recommended is kind of limiting your consumption of processed foods and saturated fat and alcohol intake to those that like the dietary guidelines for America recommends to stay within healthy ranges. Mary, if you want to contribute to that.
No, I think you
Okay.
hit it exactly well. It's kind of thinking about the DASH diet and then everything opposite of that. We generally try to
Yeah.
encourage people to eat certain foods because clients don't respond nearly as well to saying to restrict certain foods. But yes, basically the opposite of kind of this whole food, low sodium, plant-based diet that the DASH diet is the foods that would increase blood pressure. How about coffee is a good idea, a good question. I saw that pop up in there. I don't have a clear answer for that. I do think that the response is different depending on consumption habits and genetic profile. Katelyn, do you?
Yeah, that's it. So there are some studies, and this is kind of where precision nutrition comes into play because there are some studies that have shown that, well, in general, high amounts of caffeine can increase blood pressure. But then kind of habitual intake of caffeine, there have been some studies that have shown it to be protective for cardiovascular health in some individuals, whereas it's detrimental to cardiovascular health in others. And that kind of comes down to nutrigenetics. So the genetic makeup impacts how a person metabolizes caffeine, and they can either be slow or fast metabolizers, and that then impacts how their body responds to caffeine long term. So that's a tricky question to answer, and it goes into the realm of precision nutrition and more super individualized care.
Yeah, and I mean, there's definitely a low tech way to do it, which is to test it. You know, I have people test these things in their diet if they're not sure that if coffee is contributing to their rising blood pressure. You know, they have a blood pressure machine at home or something. They can track their patterns and kind of just try to learn more about how their body is responding.
You're on mute, Jeannie.
Any additional questions? If not, I'm going to pass it back to Jenny to close us out.
Oh, I think we have one more that just came in. It's a long comment.
Okay.
So this person is saying that they have never had a primary care physician talk about dietary changes or weight loss. And this person is an RD. So she is advocating for the need of referrals to RDs for dietary strategies. And I think that goes back to the raising awareness, and that's why I asked. And that's part of the reason why we have the roundtables, to bring so many various perspectives to the table. We feel like everyone has a position at this table to talk about the holistic solution. As many of you all know, we talk a lot about validated devices at the roundtable as well. That's also important, and medical nutrition therapy is just as important as that. So you know, we're here to support you all. We're so happy that you're a member of the Roundtable. We so appreciate all the research you have done. I see Marcia, my good friend, on the webinar today. And as Marcia knows, I've been working with the Academy of Nutrition and Dietetics for many, many years. And I'm a huge fan of all the work that you do and the value that you can provide to patients and clients. So thank you for all the great work. This concludes our webinar series for this year, which started last summer. We will be back in the fall with additional fireside chats. And we look forward to seeing you all. We also are hosting an annual summit in November, so look for more information on that. But I wish everyone a very healthy and happy August. And I hope you get to spend some time with family and friends before the fall kicks off in September. So thank you, Jeannie, Mary, Katelyn, for all of your work and your presentation today. This will be on our YouTube channel and it should be posted within the week or so, and I will let everyone know. So thank you, everyone. Have a wonderful day.
Thanks, everyone.
Thank you.
Thanks so much.